Good afternoon. My name is Nguyen. This is my first presentation for our DATA670 class project focused on dementia risk prediction in patients based on behavioral, lifestyle, and demographic factors. The analytics problem I'm analyzing for this project is, can we identify specific behavioral, demographic, or lifestyle factors that contribute to the development of dementia and Alzheimer's disease in patients? So currently, to diagnose dementia, a healthcare professional would have to conduct tests that measure memory impairment, behavioral changes, or judge the patient's functional abilities. And this might be done through a series of cognitive tests or through MRIs of the brain and the spinal cord. However, this generally only occurs when the patient or a family member shows concern about specific symptoms or signs of dementia in the first place. If we could identify specific behavioral or lifestyle habits that contribute to dementia, we could create a classification model using patient datasets that could identify at-risk patients for dementia. In clinical settings, this could be used as a pre-screening tool to recognize patients that have a higher risk of developing dementia, similar to the way that we have blood tests that indicate if a patient is at risk of developing diabetes based on their A1C levels, or a patient's liver function can be evaluated through protein levels, for example. To give some background on dementia, so dementia is a syndrome, which means that it can be caused by a variety of different illnesses. It's not a specific one, but it generally refers to the damage or loss of nerve cells in the brain caused by these illnesses that affect memory, thinking, behavior, and the ability to do normal everyday actions. Alzheimer's disease, which I mentioned earlier, is the most common form of dementia, uh, which contributes to 60 to 70% of all total cases worldwide, according to the World Health Organization. Now, according to the World Health Organization, 55 million people have dementia worldwide, with nearly 10 million new cases expected every year. From the ages of 65 and older, the rate is expected to be 1 in 9 people will develop dementia, though this does increase with age. When you go from the age group of 65 to 74, this increases to 5%. From the age group of 75 to 84, this increases to 13%. And then from 85 and older, 33.4%. Also, according to the World Health Organization, approximately 6.9 million Americans have dementia due to Alzheimer's. Now, the proportion of adults 70 and older with dementia has shown a decline from 13% to 10% from 2011 to 2019. However, as the baby boomer population ages, we expect to see that number rise to approximately 9 million Americans by 2030 and nearly 12 million by 2040 if current health trends continue. Now, according to surveys conducted by the AARP, it has been shown that healthcare providers overestimate the worry an adult ages 40 and older would feel if they had been diagnosed with dementia. According to the survey, 7 in 10 providers believe their patients would feel ashamed or embarrassed if they had a diagnosis of dementia, but only 1 in 5 adults, approximately 19%, actually confirmed this opinion within the survey. This concern for the patient's well-being is well-intentioned but misguided and can negatively affect the provider's interactions with the patient when dealing with cognitive function. In the survey, 9 in 10 adults ages 40 and older reported that they would want to be told of a dementia diagnosis, and only 78% of providers confess that they always tell their patients. Despite this difference in opinions, doctors maintain that they are in the best position to decide when to conduct an evaluation, with 49% of providers saying the decision should be up to the doctor and not the public. However, it can be concluded from the survey that a significant portion of providers don't know how to broach the subject with patients. The concern healthcare providers have about the worry that patients might experience when they're told of a dementia diagnosis could ultimately lead to a delayed diagnosis for patients. It has been shown that early treatment for dementia shows the best response to medication and to preventative behaviors. So delaying the diagnosis of dementia is the worst thing you could do in terms of diagnosis. Um, this attitude that we saw reflected in the survey by the AARP could also be one of the reasons why most of the research I found revolving dementia is focused on what we call reactive healthcare. Um, Many of the research projects that I found were for diagnosing patients or accurately diagnosing patients, which is obviously a big concern and very important to develop models that are capable of that. But MRIs for the brain and spinal cord aren't normally conducted for people who aren't concerned about damage to those areas already. These aren't exactly areas that are checked during a normal checkup. So if a patient doesn't have MRIs, there wouldn't be a model that could actually accurately diagnose them. And since time is so essential when it comes to diagnosis, especially with dementia, I think that there should be more research geared towards a more proactive solution. So, current research has been focused on improving the diagnostic accuracy of machine learning models, on diagnosing dementia by training them on medical imaging to recognize changes in the brain development or brain degeneration that might be apparent within specific lobes of the brain. Uh, One paper in March 2022 published their findings of a model that showed an 83% average validation accuracy, which was significantly higher in comparison to existing works at the time. And following this, in August 2022, another group produced a model that was 90.6% accurate. Um, so most of these research efforts have been focused on refining the accuracy of a model um, for diagnosis, similar to the way that we currently train and somewhat utilize machine learning models to recognize cancers. Early detection and treatment of dementia and dementia by Alzheimer's disease has been shown to have a better reception to medications and preventative measures, which is important to consider because there's currently no cure for dementia, though there are treatments that can slow the symptoms. In time, this will become a pressing public health issue in the United States, as the expected number of affected will add strain to a healthcare system that currently is unprepared and ill equipped to provide the necessary care for dementia patients. So, the focus of this project is to identify trends that could be used as guidelines by future healthcare providers to recognize patients with an increased risk of dementia and develop a tool that could screen patients who are at risk. This would provide healthcare providers with an invaluable proactive diagnostic tool, and it would also give them the context to discuss the patient's risk of dementia and suggest preventative habits and regular screenings to ensure an early diagnosis should that be necessary. The biggest focus for this project has always been the public health industry and healthcare providers, since they would be the most affected by the findings of this project. It would affect how healthcare providers interact with their patients and the procedures that providers would have to follow when they're diagnosing or just in general informing their patients about uh, what to expect. As a proactive measure, it would also improve the effectiveness of treatments for dementia patients, since early diagnosis could be more accessible. And for those who aren't affected, it would make them more aware and better prepare them for the future, either for themselves or for family members who may be affected by it later. However, I can recognize that the findings of this project, whether it was the trends that were identified or the model that was produced, could be something that would interest either research institutions or health insurance companies, for example, since they could better tailor policies for patients who are recognized as at risk for dementia, being able to customize, plans for to ensure adequate coverage for the medication procedures that they might encounter in the future. Research institutions could also use this tool for identifying clinical trial participants, either for pharmaceutical trials that might involve drugs to treat dementia or the symptoms of dementia, or clinical trials to study the effects or the onset of dementia in general in the future. Regarding the analysis I'll be doing with this project, I'll be doing association rules mining using R and RStudio for the code required for the rules mining program to determine trends on the variables for each data set and to isolate specific variables or groups of variables that indicate an increased risk of dementia in patients. The accuracy and significance of the relationships determined by the association rules mining will be evaluated by the rules lift, the confidence, and the support. Support is the relative frequency of a rule in a dataset, while confidence is the frequency of the rule provided another rule occurs. But the most important metric that we'll be following is rules lift, as this will determine the significance of the association rule. If the rules lift is greater than 1 or less than 1, this will suggest a positive or negative correlation with the variables. In this case, a variable or group of variables and the diagnosis of dementia, which is the target variable in both datasets. In addition to the association rules mining, I'll be producing a classification model to predict patients at risk for dementia, where the target variable is the diagnosis of dementia as either a 1 or 0, where 1 will be a positive diagnosis, 0 will be a negative diagnosis. I'll be using a variety of supervised machine learning methods for the model development, such as support vector machines, decision trees, and 2 different ensemble methods, random forest and gradient boosting. Now, because the datasets available for analysis were relatively small, I'll be expecting that the target variable's distribution may be imbalanced, and this could affect the training and accuracy of the model. This is partially why I included those 2 ensemble methods, as they're very robust towards imbalanced target variables. And if necessary, they can adjust for any changes that I might need to make during the analysis. The metrics for accuracy that we'll be using for the classification model will be the area under the curve, recall and sensitivity, and the false negative rate. The area under the curve value will provide a quick reference for the performance of the model, as an area under the curve value closer to 1 will mean a good performing model with a strong ability to distinguish between classes, while an area under the curve value of 0.5 would indicate a poor performing model that cannot classify any better than random chance. Recall and sensitivity will provide a measure of the model classification accuracy in terms of the ratio of true positives compared to the true positives and false negatives classified by the model. Finally, the false negative rate will give a measure of the model's error rate. As a diagnostic tool, the false negative rate is more concerning than the false positive rate, as a patient that receives a false negative may not detect their risk of dementia in time. Meanwhile, a patient that received a false positive at worst would be informed of the situation even if they aren't affected by it in the end. For this project, there will be 4 key performance indicators that we'll trace. First, can we identify statistically significant relationships between specific behavioral, demographic, or lifestyle habits and dementia? Again, the statistical significance will be determined by the rules lift, the confidence, and the support found for each association rule, where the rules lift, if greater than 1 or less than 1, will indicate a statistically significant correlation between the factor and the patient's diagnosis of dementia. Second, can the model produced by the project provide a sufficiently accurate prediction for dementia based on the datasets? This will be determined by the area under the curve, the false negative rate, and the precision recall of the classification model. Third, how does the accuracy of the proactive predictive model produced by this project compare to the other models currently produced to diagnose dementia training with medical imaging? Of the two papers previously referenced, one produced a model capable of 83% accuracy in dementia diagnosis, while the other produced a 90.6% accurate model using OASIS MRI data for training. Recently, in 2024, a model made by Cambridge University predicted Alzheimer's progression with 82% accuracy using only cognitive tests and MRI scans. I think it would be important to consider the accuracy and efficacy of the tool produced from this project with the model produced by Cambridge University for diagnosis. And finally, are the findings of this project statistically significant enough to warrant further research and analysis using larger or more varied datasets? Now, to review the datasets chosen for this analysis, the first one was called Alzheimer's Disease Dataset. It was published on Kaggle in 2024. It contains 2,149 patient records total with 35 variables. Two of the variables are identifiers, though, and will be removed during analysis. These are the following features that are included within the dataset. They include the patient identifier, the age of the patient, the gender, ethnicity, education level in 4 levels, the BMI, their smoking status, their weekly alcohol consumption, weekly physical activity, their diet quality, their sleep quality, any history of Alzheimer's, cardiovascular disease, diabetes, depression, head injury, or hypertension. Their systolic and diastolic blood pressures when they were assessed, their cholesterol in terms of total LDLs, HDLs, and triglycerides, their cognitive function based off the mini mental state examination, functional assessment score, memory complaints, behavioral problems, activities of daily living score, presence of confusion, presence of disorientation, presence of personality changes, presence of difficulty completing tasks, forgetfulness, and their final diagnosis. Now, according to the publisher, I should point out that the dataset is considered a synthetic dataset. This means that the data was created artificially through simulation based on algorithms of real-world data. Now, synthetic data won't have errors and missing data, and they can provide high quality and balanced data if provided with the proper variables, as well as provide labeled data, which is much more cost effective. At the same time, they can reduce bias by creating more balanced data sets, though it should be noted that when used in research regarding medicine, it can underrepresent specific cohorts of patients, so this bias may transfer over to the algorithms used to generate synthetic data. However, synthetic data can be used for medical research since it considers factors such as privacy laws, filtering errors, and formatting issues that could occur normally when gathering and compiling real-world patient data. However, I should consider this in case it introduces any inaccuracy during my analysis. The second dataset used in this project is called Dementia Patient Health Dataset and was also sourced from Kaggle, with the target variable labeled as dementia for the presence or absence of dementia. There are 24 variables total and 1,000 patient records included in this dataset. Now, there was little to no description of the variables or the source of the data provided by the data publisher on Kaggle. And because of the lack of units and context behind the scale, some variables will be removed during the data preparation stage. However, based on its use in other projects by other users of Kaggle and its tenure on the website without being removed by the moderation team, which did happen with another dataset I had found previously, I do believe the dataset and the variables offered by the dataset are still valuable for analysis. These are the features provided by the dataset: the presence or absence of diabetes, the alcohol level at the time of collection, the heart rate at the time of collection, the blood oxygen level, body temperature in Celsius, the weight of the patient, MRI delay, prescription, the dosage of prescription, age of the patient, education level of the patient based on years, hands dominance, gender of the patient, family history of dementia, smoking habits, the presence of the APOE4 gene, level of physical activity, presence or absence of depression, cognitive score on a scale of 0 to 10, medication history, description of their diet, their sleep quality, pre existing chronic conditions, and the presence or absence of dementia, which is the target variable. Of these variables, I'll be removing prescription and dosage as this will result in an obvious association rule since the prescription drugs included in the dataset were used for dementia patients, and MRI and medication history will be removed because they have unclear scales and no context to the measurements. Publicly available datasets were harder to find for the subject since most of them are privately owned or privately published by small interest groups or research institutions, so they're not publicly accessible. At the same time, I also understand that because these are patient records, they have to deal with data privacy and compliance laws in order to ensure that no private information is leaked to the public unnecessarily and that there's no compliance being broken when they're published. I recognize that because of the small total number of records available for this analysis, there may be an imbalance in the distribution of the target variable. So, if necessary, I'll implement a cutoff after the data preparation and transformation stages and the feature selection stage to adjust the sensitivity of the model in case the target variable is imbalanced in either dataset. Though I'm sure this analysis will work better with a larger dataset of patient data, they aren't available to the public for analysis, and I believe the features provided by the two datasets chosen still provide a very comprehensive view of non stereotypical factors that have been previously considered for diagnostic significance. And if the accuracy of the model and correlation are significant enough, I believe this would warrant future continued research by larger institutions that have wider access to privately gathered datasets. In terms of expected data transformation, there's no missing data, at least during my cursory data exploration. I will be removing specific features though. This will include identifiers, variables that aren't shared between the datasets to make it easier to merge the datasets, since many of the variables included from my first and second datasets are actually very similar. Um, Variables where the scale or the units just couldn't be determined, which mainly appeared in the second dataset due to the rather poor data description available from the publisher, and variables that might show a deceptive trend, such as the medication and dosage, which, like I said, medication only appeared in the case of a dementia patient because the medication described by it was specifically to treat dementia. In terms of expectations for the results of this project, I'd be curious to see if there are any significant correlations between hand dominance and dementia, whether sleep level, exercise, and proper diet are significant predictors of dementia, and if there's any negative correlation between rising education levels and dementia diagnosis. In terms of the model, I hope to produce one with a classification accuracy rate over 80%, with a low false negative rate and a high area under the curve to show high performance. Currently, I expect the support vector machine model to produce the most accurate prediction model, since despite the ensemble methods I chose in case of target variable imbalance, the support vector machine model is still the most resilient to outliers that might have been introduced when the synthetic dataset was created, which does make up about two-thirds of the data when combined. The next steps that will be coming up will be feature selection and engineering for preparation to combine the datasets, data visualizations for context and distributions of the variables, model selection, training, and evaluation, the next presentation and the next parts of the report, and finally the final report, which will be due at the end of the semester. These are the references I use for my project. If you have any questions, feel free to send me an email or shoot me a message using the student portal. Thanks for your time, and thanks for listening.